From Microbe TV, this is Immune, episode number 30, recorded on April 15th, 2020. I'm Vincent Racaniello, and you're listening to the podcast about the body's defenders against disease. Joining me today from Ithaca, New York, Cindy Leifer.
Hello again.
How are you? Are you well?
I am good. I am well. Busy.
Good.
But good. Yeah.
No COVID-19, right?
Well, it's in Ithaca. It is not in my house. So that's.
Do you have a lot of cases? Do you know how many?
We definitely have over 100. So that's a reasonable number for a pretty small town because we don't have any of the students in town. Both the colleges have left town, so it's just faculty and residents.
Any fatalities?
We have had 2, and they were imported from down where you are. As sad as that is, I mean, it's tragic. It's really tragic. But our Department of Health actually has a report each day that they put out, and they used to have a box that said total deaths, and now they have a box that says total resident deaths and total imported deaths. So what happened was we took some very ill patients from New York City who were unable to get the care that they required, and they brought them up here. And unfortunately, they weren't able to save them.
Wow. Also joining us from Durham, North Carolina, Steph Langle.
Hey there. Good to be here. Good to be back for our Immune Part 2 of our COVID description of immunology. And things are going fine here. We're doing some COVID research, so I'm still coming to the lab, staggered, of course. I'm not, interacting with many people. We're doing temperature screenings, and I wear a mask, so I feel very protected here.
Very good. And from Madison, New Jersey, Brianne Barker.
Hi, it's great to join you guys again. I am hanging out in Madison and teaching lots of classes online. New Jersey has been hit pretty hard with COVID-19, but I'm doing okay here. I'm trying to make sure that all of my students are okay and help them get through the rest of the semester.
How is your teaching going?
It's going okay. I am teaching everything on Zoom, and I think it's working all right. I was pretty fortunate that my lab class was actually getting into a bioinformatics section right when this happened. So that was the most difficult class, and we've been able to do a lot of data analysis. So it's going okay, but I think that both for the students and for us, it's a big change, and in some ways, a lot more work.
Yeah, I agree.
Vincent, what about you? You're teaching right now?
Yeah, my virology course is ongoing. We have 2 Zoom sessions a week. It's fine. But as you know, I record all my lectures, so I don't know, half the class doesn't even show up because they know it's going to be on YouTube.
Sure.
But it's fine. This morning I did a virology class in Knoxville.
Oh, wow.
University of Tennessee, Knoxville. The class invited me to spend an hour, and we talked, and it was great. There were 33 students there, and I'm supposed to go to Knoxville in September, so I'm hoping that we start to travel again by then because it will be fun to see them. Well, one of the students, she's got into a PhD program in New York, and she said, they said that you can come in July. She said, what do you think about that? I said, I don't know. Who knows?
Yeah.
Who knows? It's a week-by-week thing.
It
Day
is.
by day sometimes, right?
For sure.
So, Brianne, do you ever go outside or do you just stay inside all the time?
I do. There's a lot of nice areas around here where I can go out and walk, and sometimes I have to, go into town to do different things. But I am kept pretty busy with Zoom. I spend a fair amount of time indoors on my computer on Zoom.
Yeah, I do the same. I'm just here most of the day, and I walk the dogs in the morning. That's it for me. I've been trying to go in once a week. Usually the CO2 tanks or something. I have to go in Friday to do that. But otherwise, let's see, I go to the post office once a week. I wear a face mask. The post office is a funny place because they all wear gloves and face masks, which is good. But then they have this plastic sheet hanging down in front of the counter.
Oh, interesting.
Yeah.
And it's funny.
I wonder if that gets changed. every day?
Yes.
Or
Hope.
I don't think so.
Probably not.
Yeah. Well, I right before this was actually on a student's senior honors thesis defense, and she was talking about the importance of vitamin D in bone health and how sunshine and physical activity were so key. And I felt very worried about my bone health as I was thinking about my lack of sunshine and my lack of physical activity.
I have been taking my vitamin D supplements
there you go.
because I live in Ithaca. You know,
I know.
everyone in Ithaca is vitamin D deficient anyway.
Uh,
So it's actually snowing right now. So yeah.
Oh my gosh, is it? Wow.
Yeah, a little bit. It's flurrying, not a lot, but there was a coating on the ground when I woke up this morning. I just want it to be done. I like snow. You guys know this.
Oh yeah.
But once we get to like mid-April, I'm like, Uncle, please, no more.
Enough.
And especially being stuck inside, I just wish it would get warmer so we could go hang out outside and do a little gardening or something. Because kids stuck in the house all day, teenagers and parents stuck in the house all day, it's getting a little stir crazy.
Do you want to come down and visit me? It is. It's a little bit warmer down here.
It is. I know.
all right, so we're gonna pick up where we left off last time, and I'm gonna hand it over to Steph, who did such a great job. And while you're starting, I have a few emails from listeners I forgot to paste in, so I'm going to stick those in case we get to them, okay?
Yeah.
Great.
That sounds great. So I just wanted to start off by kind of doing some dipping into TWIV this week in virology, because Daniel Griffin, he's at MD PhD. He's works at Columbia, and Vincent, you can correct me if I'm wrong. He's the chief medical officer for.
So it's a physician patient network called Pro Health.
Yes.
And which is New York, Connecticut, New Jersey, 1.5 million patients, 3,000 doctors. He's the chief of infectious disease for that. Yeah.
Right. So he's really in the thick of it right now in terms of the hotbed of cases, and has been giving 15 to 30-minute updates at the beginning of those episodes. So I went through the last couple and I kind of compiled some of the things that Daniel was noticing in regards to patient outcomes and predictors or biomarkers of success or not success as to whether somebody would succumb to severe infection. And I thought we could go through these because I think they're relevant, and they're these things we are hearing about a lot in the news are kind of these hot button topics. We can work through those, and then we'll get into talking about part 2, which we didn't get to because it's just a vast topic, and that would be herd immunity, who's going to be immune, vaccines, vaccine development. There's a lot we're going to go through with that. And then we'll kind of wrap up by talking about the future. So prevention, engineering, controls, and what is it going to look like? Gosh, it's hard to predict even weeks down the road, but a year, by the history, there's been a coronavirus outbreak every decade or so. So what would a SARS-CoV-3 look like, and how do we deal with that? So I'm going to start by talking about steroids. And the reason I thought this was interesting was because Daniel was really observing that in the clinic, there was a big question as to whether steroids should be given. Now, steroids in general, they're called glucocorticoids. You make them yourself just by a natural enzymatic process when you're producing cholesterol, and it's released by your body by the adrenal glands in a circadian way, or a circadian rhythm. Interestingly, we did do an episode on circadian rhythms.
We did.
And yes, I think it was early on, and talking about how release of certain factors can affect your ability to respond to vaccines and treatments. And so glucocorticoids are similar. They are released, but they're also released in times of stress and in response to stress. And they inhibit inflammation by dampening signaling pathways within the cell. So these would be pro-inflammatory signaling pathways downstream of what we call pattern recognition receptors, cytokine receptors, and FC receptors, all things that I won't go into, but things that coat the surface of the cell. They're going to react to its environment and then tell the cell downstream into the nucleus what proteins to produce. And so by programming these or dampening these pro-inflammatory effects, it's really the macrophages that are mostly affected because they have receptors to glucocorticoids, as well as our lymphocytes. So macrophages of the innate system and lymphocytes of the adaptive. So steroids can really dampen the immune response across both arms of immunity, both innate and adaptive. And why we give them is because you likely have a pro-inflammatory reaction that your body is not tamping down on its own. And so it's treated for autoimmune disease, lupus, Crohn's disease, anything where you have this overreaction, or even, I mean, they'll give steroids. Like I had poison ivy pretty bad.
I was just going to say that I have had the same thing. Yep.
Yes. If you have very strong, like dermatological issues, then you would take steroids.
Mm-hmm.
And so usually that's prednisone if people are
yes.
thinking about what they may have received in the past.
Right.
Yes, exactly. So these are given in response to an inflammatory reaction, which we're seeing with COVID-19. But the problem is, if it's dampening your ability to recruit your adaptive immune cells, which would be the lymphocytes, so your CD4 T cells, your B cells, or even cells of the innate system that might help secrete things like interferon gamma to reduce coronavirus, you don't really want to give steroids while your body is trying to fight off an infection. And what Daniel was noticing is that if you were giving these pro-inflammatory dampening steroids in the first week, the patients were having poor outcomes. However, if you were able to give it in the second week when patients were experiencing really severe immunological symptoms, they did better. And so if we kind of tease that out as to why that may be happening, and this is all, you guys can chime in, but this is all hypothesis, because I think, we're still waiting on published literature as to clinically, what is best. But it does make sense to me that if during the first week, if you have a time where the viral titers are high, and we are seeing that in patients that do worse, their viral titers are higher than those that are doing better. And so you want to recruit immune cells that can fight off infection. And if you're dampening that response, that could be why you have poor outcomes. However, if you get to the second week and your body, because you're older or you have comorbidities, really is not good at recruiting its own immune cells, and now you have this over-inflammatory immune response, tamping it down at that point does make sense. So I think if I could hypothesize a mechanism, that could be what's happening. You wouldn't want to give steroids just as a blanket treatment, and especially probably not in the beginning. But I didn't know if anyone had anything else to contribute, but a lot of people have been asking me about steroids. And Brianne, I think you were the one who brought up allergy medications.
I did. And so the way you've just described things is sort of exactly how I've understood things as well, that much of what we're seeing in the first week might be sort of virus driven. And so there you want your immune system working kind of at full strength. But maybe later on, some of what we might see might be immune system driven, and there perhaps tamping down that immune response is important. When I moved to New Jersey, I suddenly realized that it was named the Garden State for a reason. Not that my allergies were great when I lived in Durham, but I have a lot of seasonal allergies. And one of the allergy medicines that I take is, in fact, a steroid. Mm-hmm. And so one of the questions I asked Daniel was about whether people should worry about continuing to take their allergy medication, their nasal steroids, because of everything going on with COVID-19.
What was his response to that?
So his response was sort of, we don't know. It does seem like having them at the beginning would be problematic. And so he was a little worried about the idea of having them during the first week.
Right.
When I think about sort of my own allergies, at least, I think having my allergies in check, so I am not being confused with a COVID-19 patient and am staying away from my healthcare providers and letting them do the more important work, might be a good thing to do. And so I am continuing to take my nasal corticosteroids.
Right. And so I think it's also true for people with asthma, right?
Yep.
Because that's even a little bit different category, because the allergies are annoying, to say the least, but asthma can be life-threatening if you are not taking your steroids regularly and you begin to have more asthma attacks, because each time you have an asthma attack, you're causing more damage to the lung. And so I think that at least the Asthma and Allergy Foundation of America is making recommendations saying that you should continue to take your medications unless you talk to your healthcare provider and they say you shouldn't. Mm-hmm. So I think that the advice is to, especially for asthma, to continue to take your medications, because the potential of causing the lung damage or being in a state where your body is going into asthma attack or bronchoconstriction upon exposure to the disease might make it worse. So
exactly. And I think that there also is a difference between some of the steroids that Daniel was talking about being used clinically, that might be used a little more systemically and suppressing the immune system more broadly than some of the steroids that we're using for asthma and for allergies that are much more locally delivered.
Right. Of course, it's locally delivered in the same place you're going to get infected, but, I guess,
And I think that's a part of, what I'm learning a lot about science communication is it can be challenging for people to, choose us over maybe a cable news source or something, flashy on Facebook, because ours, it can be very nuanced. I mean, I think what we're saying is that it could be that doing a nasal inhaler in the first week would suppress the ability of you to fight off infection in the upper airways before things start to get worse. We just don't know. But I of course, the official Association of Asthma and Allergy Foundation has said keep taking them. And I agree with Cindy. You don't want to predispose particularly your lungs to then getting COVID or even another respiratory infection. So keeping with the asthma and allergy medications, we all, I think, agree that you should do that.
Yeah, I agree. And while we don't know a whole lot about what is happening maybe with that medication in the first week, we also don't know what's happening if you are in the midst of having asthma symptoms and COVID-19. All of those things are unknowns, and we want to prevent as much as we can.
I think Daniel's general approach is if you're on a prescription medicine, don't change it. Talk to your doctor.
That's right.
It could be worse, like people who are on ACE inhibitors for high blood pressure. Or should we? And Daniel says, no. There's no evidence that it's bad to take them, so continue.
Right.
I read an article on that, and I think I got more confused. It's really, really complicated. And in the end, they said they might actually be helpful because there's something to do with the expression level of ACE2 going down during infection, and the ACE inhibitors block ACE1, and that actually might promote the generation of the fragments that cause more hypertension. I don't know. It was very confusing, but maybe a listener knows more about that and could enlighten us. But in the end, I think the bottom line is we're not physicians, and you should talk to your doctor. They hopefully are keeping up with what are the recommendations for them as physicians. And I would ask that question, because if they're not, then you might want to consult with a physician who is, because I think it's changing so rapidly.
Yeah, it would be really great. And I know of a couple, they don't know me, so I could approach them, but connected with with my boss who works in lung pathology and asthma and allergy. It would be really neat to have an MD on to talk about what is it like dealing with, it's allergy season, COVID-19, you're a lung specialist. That would be really neat.
Even without the COVID-19, I think it's fascinating to talk about the types of immune responses that happen with allergy and asthma.
Yeah, my sister is doing a PhD on some aspects of lung immunology.
And I have perfect timing for her.
I've recently asked her a couple of random questions, and it's been really interesting for me to learn how many things are known about lung immunology that I had no idea about and were never thought of, and how she considers sort of the lower and the upper lungs totally different organs. Mm-hmm. No one would think about both of them.
Yeah. So, well, then moving on, the next thing that Daniel had brought up was coagulation, that this was something that he was seeing potentially after trying to treat the cytokine storm. We brought that up last time, really driven by IL-6. And then you're dealing with the secondary issue of coagulation and microclotting, eventually leading to liver failure. Now, I can tell you coagulation is like my least favorite. We all have our most favorite and least favorite. It's like complement and coagulation. I just can, leave it.
Well,
I'll let Cindy take this.
We talked about complement, and I can teach it now, but it was really hard to do that at first. But yeah, coagulation is now becoming that for me, because I think that the more we learn about it, the more fascinating it is. And I think that for me, I became interested in coagulation when I realized that macrophages could throw clots. And of course, macrophages are my favorite cells. And that seems to be involved in some host defense. So then I started trying to figure out this whole coagulation cascade, which I can't say that I understand, but I have a collaborator who is quite good at it. So I rely on her. But the bottom line is, I think what we do know for sure is that there's something called a D dimer is a real biomarker for poor outcome. And so what is D dimer? I won't go into the details, and somebody so nicely put a picture into our show notes here, but basically,
I don't know if that's really going to help.
But basically what happens is, if you cut yourself, you will clot, right? We all know this. It's very simple. And what we don't think about is, well, that actually serves two purposes. One is you have to stop bleeding. Otherwise, if you don't stop bleeding, you'll die. And so that's number one. But clots also trap microorganisms that might have come in through those openings. And so in essence, they're preventing the spread of microorganisms into the body. And this is really interesting, because if you look at lower, like invertebrates, like flies, they have a process called melanization. And so they basically create a wall or a barrier when there is a breach in the carapace, or whatever you call it, the outside exoskeleton of the insect. When it's pierced and bacteria get inside, they wall them off. And that's a main mechanism. And so this clotting is actually a main mechanism to trap and block off bacteria and potentially viruses. So nonetheless, this plays a role in host defense. But what we're seeing in the case of COVID-19 patients is that there is this cytokine storm, which is this massive influx of pro-inflammatory cytokines, and that's going to promote changes in vasculature, vascular leak. There's going to be things on the wrong sides of blood vessels. And when that happens, just like when you have a cut, you're going to get clotting. And there's going to be deposition of something called fibrin. So that's a main part of a clot. And then what happens is, when that clot, as we know, starts to go away, it gets digested and eaten up, and it gets replaced by new extracellular matrix. And so that's when we have a scar or, a wound healing like that. But in the case of these microclots, what's happening is the clot forms and then it gets digested. And when it gets digested, it releases these D dimers. So what the presence of enhanced levels of D dimer is telling you in the blood is that there are clots happening. And they're happening at a decent level, that enough so that you're able to detect these fragments that are being digested from the clot, because it's trying to remove these clots. So now you have these clots and you're trying to remove these clots. The other interesting part about coagulation is there's two phases. So there's a hypercoagulation. So there's the formation of these clots. And then there's when you use up all of the clotting components, you end up hypocoagulant, and then you start to bleed out. And this is something that we see in sepsis. So when you have a high level of bacterial infection in the blood and you get sepsis, you get what's called disseminated intravascular coagulation, or DIC, and this can happen in COVID-19 as well. And so you get these clots everywhere. But if you can't rescue the patient at that point, it kind of flips over and it becomes hypocoagulant. And so the vessels start to get leaky, the blood pressure drops, and you start to go into shock. And so in the case of COVID-19, what's happening is you get this hypercoagulation at first with these little microthrombi that can get stuck into vessels that feed into different organs. And so the organs start to become compromised and shut down. But then also, if it goes too far, now you have this fluid that starts to leak into the lungs and leak into other tissues. And then it becomes a real problem. So D-dimer is not, I would say, not a great outcome. If you're starting to see that, you're in pretty bad shape. And if they can't rescue you at that point, it's not looking good. So I think we do need to look at earlier biomarkers. And so I think the next thing that you had, unless you had a question about that or you wanted to talk more about that, I think the next thing is, can we go earlier than that, that moribund biomarker, that's way closer to a poor outcome? Can we look earlier and see if there's something we can read out?
I mean, why, this is the question, and it's in the notes, why would SARS-CoV-2 infection cause coagulation and D-dimer increase? I don't understand.
So there's two things. One is just the massive amounts of pro-inflammatory cytokines will change the vasculature. Mm-hmm. But the other interesting thing is that virus infections in general, and it has not, as far as I know, been studied for SARS-CoV-2 at this point, but some viral infections, at least in macrophages, for example, can cause changes in surface expression markers that will promote clotting. Mm-hmm. And so in the case of macrophages, what will happen is you can have flipping of what's called phosphatidylserine, which happens when cells undergo apoptosis as well. And that will activate a protein called tissue factor on the surface of cells and cause them to be procoagulant. So there's potential that the infection itself is causing this, or it could be secondary to the cytokine storm that's happening as well.
What's weird is that this is just coming up now. Daniel mentioned it for the first time last week, and patients have been cared for quite a while. So I wonder why this is happening now or being detected now. And we didn't see it before.
When I looked at some studies that came out several weeks ago, they were saying D-dimers were up in the patients who died.
Yeah, I just go by Daniel, and he never mentioned it before.
Maybe they just started looking for it. I don't know.
Yeah. And what's interesting. So this time, what we're talking about, what Cindy's mentioning, it's late. And really, there's likely very little detectable virus. And so earlier in infection is really going to predispose your system as to whether you're going to be able to have this severe of an event, or are you going to be able to recruit the immune cells to tamp down the inflammatory affection and inflammatory response rather, and be able to balance it. And so that's seemingly the pathology. I do think it's immune in terms of severe disease is immune based.
Cindy, what's the implication for blood oxygen supply if you have high D-dimer? Is there any?
I don't know.
Because you say that if you have an embolus, that can obviously block blood supply physically, right?
Correct.
But, there's this other observation besides high D-dimer that these patients, some of them do not have ARDS, but rather have a high altitude oxygen problem, that mimics lack of high oxygen at high altitudes. And I don't know if it's connected to the clotting or not.
That has been really fascinating to even understand. And from reading and listening to what Daniel said, it's not every patient, but it's seemingly like maybe 30 to 40% where they're not experiencing. So with ARDS, I mean, the body, once it detects damage, is going to block off that area of the lung. And so that's why you need oxygen, because the body has blocked off that area and you can't get oxygen to it. So your blood oxygen is very low. But seemingly with this HAPE, or high altitude, what was the P stand for? High altitude pulmonary edema. It isn't blocking off areas. So you have a lot of oxygen in your lungs, you or in your blood. You don't need additional oxygen, but for some reason you still have lower pressure, and your lungs are still failing from the edema. So I don't know if that. I mean, I think that's very recent observation that they're going to have to follow up on, because seemingly that would be a different treatment that you wouldn't want to ventilate.
Yeah, that's what it sounded like from Daniel.
Yeah, he said they're not ventilating. They put you on your belly to improve.
Yeah, I read
it's easier to breathe there or something. Yeah. I will have to ask him that on Friday. Because I often don't want to ask too many questions because he's got a half hour and I want him to get out. And it's not like we have time to chat, because apparently all his physicians are listening in the first half hour to get information. So
Sure. They're like, then we got to go.
Wow.
I don't know, Cindy, we did have one more thing about other biomarkers. We could touch upon that.
Yeah. So going a little bit earlier when we're talking about the cytokine storm, I think it's interesting because everything was focusing in on a cytokine called interleukin 6 or IL-6. It's certainly not the only molecule that goes up when there's a massive inflammatory response. So you have here procalcitonin, which I'm not that familiar with, but C-reactive protein is a acute phase reaction protein secreted by the liver. And so they definitely are correlated with poor outcome. But I also saw a recent paper where they started to do sequencing analysis of PBMCs and of bowel cells. And, IL-6 was not up there. So although we're seeing IL-6, I don't know who's making that. I would have thought it was the macrophages, but I'm not really sure if it's the blood monocytes or tissue macrophages or velar macrophages. It might be from another source. But it's interesting that there's certainly IL-6 is not the only cytokine. Is it the most important one? I don't know. I think we'll find out because people are trying to start to use anti-IL-6 therapy. So there's been it got advanced. It's tacrolimus, I think, is advanced now into like a phase 3 trial for this because it was already being tested in phase 2, phase 3 trials. So they're, I guess, enrolling patients throughout the world. It was crazy. I saw something that they treated like 200 or 300 patients in a 24-hour period because it's a global, mobilization of a clinical trial, which is another fascinating aspect of this whole pandemic. But yeah, so I guess we'll find out soon enough whether it will or will not be helpful. But the idea there is IL-6 is a major promoter of the fever and other tissue changes that occur in response to the cytokine storm. And so finding out whether that's a good target or not, we'll know in a couple of weeks probably.
Sure. So I think our summary from that section is you do not want to get to the point where you have a cytokine storm and increase IL-6. It seemingly before that, finding ways to either through biomarkers or treatment options to make sure that you don't have this type of high pro-inflammatory response.
And it seems like that response is happening maybe more in the second week than in the first week.
Exactly. Right. Yeah. Which is an interesting thing because also, where do we call it the first week versus the second week? Because now we're hearing a lot about asymptomatic, right? So is that from someone when they first test positive, or is it from when they have a first symptom? Or, because as far as the immune system is concerned, once you are exposed and the virus starts to replicate, we would call that day one, right? Because approximately 5 to 7 days later is when you're going to have the real exponential phase of your T and B cell response. And so we would call, after that 7 days, that would be week 2 because we know the T cells and the B cells are becoming very active and then they start contributing to the pathology. And so where do we
this might really be week 3
2?
Or week 4?
Yeah, we don't really know, right?
Yeah. So, okay, great. Well, that section was great. I think we're looking at, we have about 50 minutes to get through the next section, which is going to be a bit of a monster, but I'm excited for it because, of course, it deals with adaptive immunity, which is opposite of coagulation, my favorite part of the immune system.
Well, you like your part, I like my part. So.
Yeah, exactly. No, I know. I
That's
tease.
perfect.
That's why we all, we all kind of find our little niches and what we love. So, so we're going to talk about herd immunity first. It has been hotly talked about, and what does it mean, and specifically for COVID. So herd immunity in general is when a population is immune to an infectious disease, and this provides an indirect protection to those who are not immune to the disease. And there are 3 ways. 2 ways. One has like a part A and a part B, but I'm going to say 3 ways to develop herd immunity. The first one is quite draconian, and I would not advise as a public health official who cares about the health and safety of society. And that would be to let everyone get sick and then let everyone recover and just see who ends up dying and see who ends up surviving. And the ones that survive are the ones that are immune, and you have likely herd immunity. Now, that was something that there was a lot of press about England wanting to do that. And then I think they realized very quickly that the percentage of people who would die would be higher than what you would just expect for COVID, because the overwhelming of hospital systems means that people who have COPD from lung damage or other maladies would also die because they don't have enough ventilators or treatments, doctors. I mean, the healthcare system, people in healthcare cannot all get infected because then who takes care of those patients? So that's the first way. The second way,
and I have to say that was really shocking to me when it came out in the news that they were going to do this, because we had already been dealing with this for weeks and weeks, and it was very clear, country after country, that was not an approach that was going to be a viable approach. And yet they said, we're just going to lock up our elderly people and just let everyone else get sick, right? Which doesn't make sense because you can't keep everybody in. And on top of that, it assumes that only the elderly are really susceptible, and we know that's not true either.
And that exactly. Right. There are young people dying. Of course, it's a lower percentage, but we see it happening. So yeah, that was shocking. And, you hear people suggest that in like weird corners of the internet, but like for a country to say that's their policy was very bizarre. But they did quickly.
Anti-vaxxers believe that too, by the way.
Oh, well, I know. I mean,
natural infection is best is their argument.
Yes.
Except for when you die.
Yeah.
Well, right.
Unless you die.
Or your family member or something. Yes. So the second way then, of course, is a vaccine. If we have a vaccine that we can give up, a majority of people, then that could prevent herd immunity. And then the third way is really what we're doing now, which is a very public health based approach where we are social distancing. We have canceled much of our economy. I don't mean canceled. We have shut down much of our economy, and that's the flattening of the curve. And out of these three things, when you don't have a vaccine, you're left with let everyone get sick and have a lot of people die, or social distance and have economic downstream effects, which are also going to be very bad. So I'm not here to say that what we've chosen doesn't have any consequences, but I do think out of the two that it's going to be the best for a society. And
this is an interesting thing to think about, because we often think when we talk about immunology, what's going on in a cell, right? Like what happens when a cell is infected? How does it respond? Or an individual. Well, what happens if the individual is infected? How is their immune system mobilized? But this is thinking of it more in a community way, right? And so it is indirectly impacting the individual.
Yeah, and population immunity is really interesting.
Yeah, and so then it becomes an interesting argument, because those individuals who feel like maybe they wouldn't be impacted by it, but are impacted by societal changes that are made, get very frustrated if they don't understand, how what they do on the individual level in the community is helping others. So it's an altruistic type of community interaction in order to make this work.
It is, and you can never, you don't have the sort of controlled study to say, oh, you would have been affected if we didn't do this. Right. You sort of just have to be imagining that.
Yeah, we can't section off a part of the population and say, okay, you guys don't do social distancing.
Well,
I guess
those
that's true.
Unintentional studies happening, right?
Between countries, maybe even between regions. That is
yeah, between states, between countries. It'll be interesting.
And, the number in terms of percent of people that need to have antibodies that protect them against a future infection, I think that's kind of debated. I know 70% is what a lot of epidemiologists say, but it really depends on how long immunity can last, how infectious it is. So it can range from 70 to 90%. I think in measles, you need a very high proportion. Correct me if I'm wrong,
because it is
right. It is so infectious that any break in kind of our herd immunity can cause infection. So that leads us to we can break down exactly how vaccines work in a general way before we start talking about this big question of if you get infected, will you be immune?
Right.
I'd be happy to do that, or Cindy, if you want to, it doesn't matter. But I'll just kind of start in a general way, and feel free to pitch in. You're going to get vaccinated likely intramuscularly, and inside that vaccine is going to be a piece of the virus. It can be a weakened part of the live virus, or it can just be a subunit or a piece. And within that vaccine, you likely also have something called an adjuvant. And those two things are going to work in concert to stimulate something called a dendritic cell, to be able to pick up that piece of antigen or that piece of virus called an antigen and process it so it can present it to CD4 T cells in the lymph node. Now, the adjuvant's very helpful because you think about a muscle, you don't usually have a huge amount of dendritic cells, but it's going to activate cell types to secrete proteins to have the dendritic cells start to migrate there. Or the piece of virus is going to travel through your lymph and go to the lymph node where there are a lot more dendritic cells. But yeah, go ahead, Cindy.
Oh, I was just going to say, and so for those who are not aficionados, we often think of lymph nodes as those lumps in your neck when you're sick.
Yes.
And it's because all of those cells accumulate there to try and educate each other and learn and become activated and then go out and do their job in wherever they can find the infection. And so the swelling is both the lymph and the number of cells that are there because they make copies of themselves and more of them.
Right.
Yeah.
And I'm only going to talk about 3 cells just to keep it simplified. The dendritic cells that pick up the protein, because there's a lot more going on, but dendritic cells that pick up the protein, they present it to T cells, and T cells are going to then help work with B cells to make antibodies. And antibodies really are what we think of, what we're trying to develop memory for a future infection that a memory B cell and memory T cell can work in concert to then protect you in the future. And
when you say memory, can you just expand on that a little bit? Because I think that's the key point with vaccines, right?
Sure. So the first time you see a virus or a pathogen, or the first time you see anything in your immune system, you're going to develop cells that are going to remember that pathogen. And they start as naive cells. They don't know any better, but then they're going to develop this memory. And so they can in the future expand at a greater rate than when they first saw that pathogen. So the second time they see it, you don't have to wait 2 to 3 weeks. Maybe you only wait 1 week. And that quicker response is what we define as memory. So, and not only the response rate, but the ability to produce more antibodies that can bind the virus and neutralize it.
It's sort of a quantitative and qualitative improvement that we see in those cells. And the important thing about the lymph node, as Stephanie was mentioning, is that we need all of those 3 cell types to work together to make all of this happen. And the lymph node is sort of the place where that can happen. And it's really nice to have a place to collect up all of those cells.
So I sort of think of the dendritic cells as the detectives that kind of go and find the piece of information, right? But then the memory cells sort of keep track of those fingerprints of the different microorganisms, so they can look for those fingerprints. And so if you're trying to solve a crime, if you have a fingerprint in the database, you can solve that crime much faster, right? Than if it's a fingerprint that you don't recognize and you have to try and figure out what happened. So if you have a new infection, it's a new fingerprint. They've never seen it before. And so you have to mount an entirely new response. But if you have a fingerprint that in your database that you recognize, you can go after the criminal really fast. So the B cells and T cells can be mobilized really fast the second time around.
Right. And so that leads us to then this big question is, if you get infected, can you get reinfected? And there's a couple different things to think about. We can look at past studies. So we know that SARS was a pathogenic coronavirus, MERS is a pathogenic coronavirus, and both of those have shown that you can develop something called neutralizing antibodies, or antibodies that block the ability of the virus to enter your cells. In some cases, we had talked, there's a link that they could wane after 3 to 6 years, but I know Lympho Wong had looked at MERS and it lasted up to 14, not MERS, but SARS lasted up to 14 years, and you could pull out those antibodies and they still neutralized. So pathogenic coronaviruses, there's some evidence, but of course, SARS really disappeared after 2004, and we didn't get to learn a lot about long-lasting immunity.
Right.
Now, there are human common cold coronaviruses, and what we know about their ability, or our ability to develop immunity against them, is it's not great. We get reinfected with common cold coronaviruses. They last maybe 1 to 2 years, but I wonder if it's the difference in the fact that they are a more mild disease, They possibly are presented to these important cells in your lymph node in a different way. So when we think about developing a vaccine, you want something that is going to powerfully present itself to the B cell and have this high affinity response to the pathogen. And we're still learning. The problem is, of course, we're early. There are some papers that show that you can get neutralizing antibodies to SARS-CoV-2. And if I had to put a bet on it, I'm going to bet on the adaptive immune system to be able to make those antibodies. But it's not going to be what we call sterilizing immunity, is my guess. I think that, and sterilizing immunity is really, you would see no trace of the virus. You wouldn't see replication. Your body has been able to fully protect you and neutralize it. But I think with a vaccine, we could get there. So that's kind of my thought on this, is that we can develop neutralizing antibodies, but we need a vaccine for this longer term protection.
Right. And the idea with the vaccine is basically you are trying to show your immune system some part of that microbe, and, get the fingerprint in the database without having to have disease happening first. And so you are really trying to sort of mimic the first part of this in a safe way.
Yeah, it's like a fire drill, right?
Yep.
you pretend that there's an infection. You do everything you need to do so that as soon as there really is one, you can go quickly.
Right.
So,
and a lot of the kind of onus on making sure this works is in the vaccine. What is going to be the antigen that we present to ourselves? And the antigen, again, being just a piece of the virus. There's something called an S protein, the spike, and that's around the coronavirus. And previous studies have shown that protein is very important in developing these neutralizing antibodies. And so a lot of the vaccine development is a vaccine that presents this spike protein to your immune cells. And there are different parts of that spike protein. So I think what people are trying to figure out right now is, what part of that spike protein do we want to drive the antibody response towards? And these are all things that they're going to start testing in clinical trials. There are a lot of vaccines under development. I mean, I'm very familiar with the mRNA vaccine, but I'm sure there are tons others. I know that the mRNA is in clinical trial right now, and that's just that you're injecting the more basic form of the protein. So the RNA that can be then translated into the protein of interest. The reason why they were able to come up with that so fast is really you're just plugging in the sequence because that platform had been developed.
Right. And I think there's a nice thing to learn here too, is that we learned a lot from the original SARS, and we learned about the types of antibodies that are generated and whether or not they're neutralizing. And it was really important. And so some of what they've done is develop specific stabilized structures of the protein to which the antibodies are generated that you use in the vaccine, so that you're generating antibodies that are much more likely to be neutralizing. And so they call it like the stabilized prefusion form, so that when you generate the antibodies to the vaccine, it's generating the ones you want. And so, yeah, the one that's the lead candidate right now is the mRNA vaccine in a nanoparticle. The other cool thing about that is that the nanoparticle itself is adjuvanting. So it is itself the adjuvant. So there isn't anything else in that formulation except the nanoparticle and the mRNA.
Yeah, and this is a type of vaccine that is different than sort of the vaccines people have already received. It's a newer technology.
Right.
And so this is sort of the first big test for this technology. It's really exciting because we can make these vaccines so quickly. And so if this one works well, that's going to be generally really exciting as an idea that this is going to be a way we can make vaccines quickly in the future.
Yep.
Right. So there had been a lot of press, particularly when a lot of the genomes or the genetic information of these viruses was being published in this open source it's called nextstrain.org. It's very cool, out of University of Washington. We can put that in the show notes. But there is a lot picked up by the press that there are 8 strains of coronavirus circulating, and it's based on mutations. And can we develop immunity to all of these strains? But really, what I think is missed and is the nuance, is the difference between strain and just mutation. So for viruses, they're mutating all the time, but it does not always confer something that matters, something that's functionally relevant. You have a buildup of mutations, and in coronaviruses, actually, it takes a lot longer to develop these mutations because of its nice self. It has a way to fix those mutations. So there are not 8 strains. There is 1 strain, although we're seeing some evidence of maybe a deletion of a part of the virus called ORF8. It's a non-structural protein, and maybe that will matter. But remember, ORF8 is not a driver of neutralizing antibodies. It's the spike. So likely, as we've seen with other coronaviruses, the one I worked on in my PhD, there was a different strain that emerged called an indel, an insertion and deletion in the spike protein, but it made the virus less virulent. So there was one other strain that emerged, and it was not more virulent. So I think that's something to keep in mind, that it's unlikely that we would have to worry about these mutations in terms of immunity because they're not functionally relevant.
As Stanley Perlman mentioned that yesterday, is this the pig virus that basically it ended up immunizing pigs and this new isolate, and it got rid of the original virus?
Oh my gosh. So that story is even more fascinating than the PEV one.
Oh, that's TGEV, right?
Oh, that's TGEV. So Vincent, Cindy, Brianne, correct me if I'm wrong, but there's not been another example of an enteric virus that mutates to get different tropism in the lung and then is able to basically build immunity in the animal for both viruses. Yeah. So porcine respiratory coronavirus was a mutation from transmissible gastroenteritis virus, 2 different tropisms in the body, and they ended up kind of the gut one ended up not being pathogenic because the respiratory one built immunity in the pig. It's an amazing story.
Well, there's the opposite that happens in the cat, right? Well, so there's an internal mutation that causes the FECV to be FIPV. It's feline infectious peritonitis virus. Yeah, and that makes it worse.
Right, and that makes it worse. So this one made it, I guess, the opposite.
Better. Yeah. Fascinating.
So, fascinating.
And one of many reasons we should continue to be looking in some of the different animal models, not just the standard ones everybody always works on.
Right.
Listen, stamp that on my forehead. I just want everyone to know that.
Well, on TWIV before SARS-CoV-2, we used to talk about some of these other coronaviruses. I think we have to return.
It's taken over. Yes.
So the nextstrain.org is interesting. Nell Zeldy and I talked about it a few weeks ago. Between all the isolates from the beginning of the outbreak to the current, there are just 20 nucleotide differences. That's how stable this virus. It's only 20, and none of them, as Steph said, have any functional consequence. They're just markers. And Christian Drosten used one as a marker. So he found in one patient a virus in the upper tract that was 1 base different from the virus in the lower tract, just randomly, right? And they could tell that it was just the virus from the upper tract that was transmitted to other people. Using it as a marker, showing that that's where you transmit virus from the upper tract, which makes sense because it's hard to get stuff out of the bottom of your lungs to other people, right?
Mm-hmm. Wow.
Yes. So, I think, and there's been debate back and forth, and I think different people can weigh in, different experts, but in terms of generating a vaccine, and then the question is, are you going to drive evolution of the virus towards something? And my opinion is just because of the way coronaviruses work, that you would not. And also, I think the virus would either burn itself out or become so mild that the pressure is gone to change, quote unquote. And even if it did change, it'd be less virulent. But I'll let you guys comment if you have other opinions.
I have no idea.
No, we believe you. We believe you.
I agree.
So we're going to make this vaccine. Likely, everyone, I'm going to say everyone, but there are going to be pockets of people either for access reasons or for belief reasons are not going to get it. But we could say that this is going to be a widely distributed vaccine. And so it would be particularly bad if antibodies against this vaccine made the disease worse if you got reinfected. And there are examples of this happening, and really one major one, and that's dengue. And dengue virus, you have an enhancement disease because the antibodies from a different serotype that you previously were infected with are not neutralizing for a new serotype, but then these antibodies start to coat the surface of cells that they don't act appropriately, and you can actually have an increased amount of infection in the cells themselves. And so I think that's been a big question in the field. That there's a couple studies, and we can talk more about them, but generally coronaviruses haven't had this issue of antibody-dependent enhancement, except for one, which is that feline infectious peritonitis virus. But that's because that virus infects macrophages.
Right.
And I think it has a lot to do with bringing antibodies in close contact with macrophages as their main tropism cell. And then you start to the FC, if I'm holding up my hand in a Y shape, the top, my two fingers are what binds the pathogen, but the long part is what can cause a lot of this damage from antibody dependent enhancement. So I don't know. I don't really think we're going to see that, but if you guys have thoughts on that.
Yeah. So my understanding of the dengue situation is that the antibodies help the virus into macrophages. And so it's sort of changing which cells get infected. And there's a paper that a lot of people are talking about anti-spike antibodies. And it seems like what's going on there is a little bit different, that instead of changing which cells can be infected, there are changes in what types of cytokines cells are making in response to the infection. So it's actually changing the macrophage from one type of macrophage to another. And so it's a bit of a different type of phenomenon. There was a recent TWIV episode where we talked to Stanley Perlman, and he was really helpful in talking about this, and because he had done some studies on this.
Right. Does he agree that it's probably not going to be a thing?
He noted that there were differences in the macrophages that were seen in macaques. There were no differences in the pathology and the disease that was seen in the macaques. And so he didn't seem to think that it was particularly important for the disease, although he said they didn't look long term at the macaques to see if there were differences in the lungs much longer after infection.
He also emphasized that it's different from ADE, right? As Brianne has been saying, yeah.
And ADE is what we're mentioning here, this antibody-dependent enhancement, when the antibodies bind to the virus and actually promote its internalization into a cell that it doesn't normally infect typically.
Yeah, that's the dengue thing.
Right, exactly.
Is that a scientific term, the dengue thing?
I like the dengue thing.
Dengue thingy.
I'm pretty sure it is.
But so I think we're all on the same page that it's probably not going to happen with this. And I think that, what I was saying earlier, where they're using this pre-fusion stabilized form of the antigen to promote more neutralizing antibodies versus non-neutralizing antibodies, should also help with that as well.
But I do, yes, and I agree. And I think I do get the concern, particularly from vaccine companies, because it would be really bad if it even was a potential. So I understand the concern.
It would be really bad.
Yes.
And that's why we need to do safety studies, right? I mean,
and that's
people
why
want
it takes
to roll
so long.
these things out really, really quickly, but I don't think that is entirely prudent. We need to be really careful.
So Vincent had a question, and maybe Cindy had an answer.
So Vincent, you were wondering that if you get passive antibodies, would that block your own response to the virus? So we're talking about a major therapy that's it's been all over the news, is this convalescent plasma. And so when you take the the blood, the liquid part of the blood from people who have recovered from the disease, it will have presumably antibodies that helped them survive the disease. And so if you take those then and give them to a very ill person, the theory is that it has antibodies in there. Well, that will then help them as well. Now, the caveat to that is we talked about early versus late infection, whether you have a lot of virus or a little virus. So that's a question still. But the question is, if you gave somebody these antibodies, this passive antibody therapy, would it block their own immune response? And I would say the answer is probably yes to some degree, depending on when you give it, because we know that, and Steph could probably speak to this more than I can, that when you have a baby, for example, that's nursing and they're getting antibodies from the mom, those antibodies are protective. And some cases, there's multiple reasons why, but there's some cases where those babies will not generate an immune response to something that they might be exposed to. And so the antibodies might actually bind the infectious agent before the baby's own immune system generates an immune response. I might not be 100% correct, but I think there is a possibility that it would block the response. What do you think, Steph?
Yeah, I think depending on how high the concentration is, I think it's a little bit different because with the baby, it's longer lasting. So you can't really give convalescent serum for consistently for many months. And that's kind of the situation that you would have with either, after placenta, the IgG wanes over like the first 6 months, and then breast milk, it's over a long time too. But I think probably what they're weighing is the FDA, from what I understand with convalescent serum, they approved it only for severe patients. And so likely your risk reward is, well, even if we slightly suppress their immune response, they're likely older and they need protected more than we can worry about that. That's probably my take on that risk factor.
Yeah, I would completely agree. I know when you are making a memory B-cell response, and you have antibodies that have already been made and that are already IgG antibodies that have already class switched, those antibodies are able to actually suppress activation of naive B cells.
Yep.
Naive B cells have a receptor on their surface for IgG, so they sort of get suppressed while the memory cells are acting, because we don't want to have both naive cells and memory cells sort of using up resources. And so in that way, I would expect that the passive antibody might block making a naive B cell response. But I completely agree with Stephanie that when we have patients who are extremely sick, the first priority should be to help them feel better now, and more so than thinking about their later immune response.
Yeah, I wouldn't worry so much about the later immune response. What I'm actually more worried about is if you don't know why those people are really sick, I'm not sure it's going to make a difference. So is the
virus gone by that point?
Right. If their own body is failing to mount a response for some reason, which we do see example that people are saying that there are certain individuals who are not mounting a good antibody response, right? So in those cases, providing those antibodies to them in a passive way should help those individuals. But if somebody has already mounted their response, the virus is mostly under control and the pathology is being mediated by the immune response, I'm not sure it's going to help.
Yeah, I think these convalescent trials are going to show that it doesn't help if you give it to a patient later in illness, because even when this more serious lower tract illness begins, the virus is already decreasing in the upper tract by then. So
yeah,
it's not going to help. It's helping earlier, but who knows who are going to be the seriously ill patients? That's a problem.
Yeah.
Wow. Okay, great. So we're kind of on to our next section here. I think we can talk about, Cindy, the testing, the diagnostic test, and that might roll us right into serology testing.
Yeah. So
that's about.
So there's two main tests, and there's a whole lot in the news about tests and whether they don't work or they do work or whatever. And we could get into whether they quote unquote work or not, or I don't know. But the bottom line is there are two major classes of tests. One is testing whether or not there is virus present. And that's important to say it that way, I think, because it doesn't necessarily mean it's infectious. And those of us who work in this know that in order to demonstrate there's infectious virus, you have to do a virus isolation and culture and show that it's actually live, I wouldn't say live, replication competent virus, which means it could infect new people. So if they do a swab and stick a swab way up your nose into the back and they swab it or down your throat, they're going to do what's called a PCR test. And that's polymerase chain reaction. And I was reading about this. It's fascinating because I did not know about the loop amplification mechanism. It's a PCR that they can run isothermally, so at room temperature, or at least at one temperature, I would say, and it can be done in 15 minutes. I was like, whoa, that's so cool. Anyway, because I we do real time PCR, and I think that's great because you can detect it in a couple of hours. But so the test is basically, if this is an RNA virus, but to do polymerase chain reaction, you need DNA. So we turn the RNA into DNA, and then you amplify it. And basically, the more copies, the more fluorescence you get because there's a probe in there. And so you can tell if the person has the virus present or not. So have a virus that you can pull out of them. Usually if you have symptoms along with that would be considered a diagnostic positive. But there's issues where maybe a person has a lot of symptoms. It seems like, it looks like it and it smells like it, but when you test, it's not it. And that could be just a failure in the testing. So there's this whole thing of, is a positive test a positive test? Probably yes, it's pretty accurate. But is a negative test, maybe not. So that causes a lot of confusion in people, trying to understand how all of this works. But so that's the main test that they're using. And to do that, you do need pretty sophisticated equipment to run these PCR reactions to be able to test whether there is virus there or not. And the other thing is you need to be approved to do this by the FDA. And then you have to demonstrate that you can accurately detect positives and that you're not detecting positives where they're not positive and that they're negative when they're supposed to be negative. And so there's a lot of, certification that you need to go through to be able to do that. Now, as I understand it, they're sort of relaxing the rules on that and it's becoming the Wild West. And so it's not clear that every test that every company is putting out is as accurate as that should be. And so that could be contributing to some of the negatives that we're getting that may not actually be negatives, but they are in fact positives. But so that's the first test. Did you guys want to comment anything about that?
I just want to say there are these reports coming out of Korea and some other countries that people are getting reinfected, quotes. Yep. But I think those are failed negative PCRs. And these people are just shedding pieces of RNA, not infectious virus by that point. And then they just test them a week or two later and the test works and they're still shedding pieces of RNA and they say they're reinfected, but I don't believe that they're actually reinfected. The original infection is just going on. And we know now that RNA virus infections can shed bits of RNA for a long time after the virus is actually gone.
Yep, exactly. I think that with this PCR, one thing that people should know about it is that the answer that you get in the lab is a number.
Right.
And then we take that number and sort of make a decision about whether that number means positive or negative. And in some of those patients, who went negative and then became positive, they were really fluctuating right around the cutoff line. Mm-hmm. And so this might be more about what cutoffs we're using for positive and negative, as opposed to the patient actually really having zero virus and then having the virus come back or allow them to be reinfected.
And it's the nature of this kind of amplification style of testing because if there's bits of anything in the air or, on any surface that when you run these tests, if you go long enough, pretty much everything will eventually come up positive. It usually is very rare that something stays negative for, many cycles. And so we do this based on when a positive known control comes up and when a water or negative control comes up or doesn't come up. And so then that's how you set the cutoffs. And so it's not an exact black white. We think of things like a pregnancy test, you pee on the stick, it's positive or it's negative, right? And so sometimes is that really a line there or is it not? That can be a question. But some of these other tests that we're talking about are not so black and white. Now, if you pee on the stick for a pregnancy test and it's black and white, you're actually looking for a protein in the blood. And so you can detect proteins, or you can detect antibodies by a similar mechanism. And so there's what's called a serology test or an antibody test. Now, the antibody test is getting a lot of news lately because everybody wants to know whether they have been infected or not, and whether they are now safe to go back to work or to go outside and to socialize. And the presumption is if you have an antibody test come back positive, that your immune response has kicked the virus, and you're good to go. And so what those tests are looking for are antibodies in the blood or in secretions. So you can use saliva sometimes, or, even the nasal secretions. But there's several different ways that test can be done as well. The most accurate way is what's called an ELISA, where you look for those antibodies and you can actually quantify how much of them are there. And we're saying them because there is more than one class, and I'll let you talk about that a little bit, maybe Steph, in a minute. But the other test that's being developed is a rapid point of care test that probably is going to become the norm as we move forward. And that is, you'll be able to take a sample, you'll put it on the end of the stick, and then it will slide along. And if it binds to something that's a control, that will tell you if it's there or not. And it's usually like gold or some other reagent that if there's an antibody there, it will get reacted, and then it'll come up as a line as a positive. And then there's a positive control and a negative control on that sample as well. And then you read whether there is or is not a line there, and that'll tell you whether you have antibodies in that sample or not. And so, yes, in theory, you would not have any antibodies if you have not been exposed, and you would have antibodies if you were exposed. So that's theoretically what would happen. But there are nuances to that as well. So I don't know if you wanted to go into any more about that, Steph.
Sure. Yeah. Wow. Yeah. The serology testing. I mean, I would argue an even more challenging assay than the PCR assay in terms of creating something that's highly sensitive. And by sensitive, I mean the ability to correctly identify patients with the disease. And then also highly specific, which is the ability to test and ID patients without the disease. And that's kind of, excuse me, why there's been a lot of controversy, because the FDA has relaxed regulations. And so before, when you were creating a serology test to look for an antibody, a company would have to submit data to the FDA to then be allowed to sell this as, a diagnostic. But now they're able to sell it and then send the data to the FDA, and then the FDA can then decide, but they're already selling it. So you might see in the news, people who are receiving boxes of serology test kits that they're all defunct. They're not sensitive or specific enough. And why is that the case? So there's a couple different reasons. For one, what the antibody binds to in the test has to be something that is highly recognizable by the antibody. And so we've talked a lot about the spike protein. And so likely it is the spike protein that is being put in the test for the antibody to bind to. But it could, you might want to double your chances and put another protein down in there, which could be the nucleocapsid protein, because there's so much of it's the most amount of protein in the virion. So how is that produced? How is that protein produced? What's the conformation? We make these things in cell culture. What was the type of cell you used? How did you purify it? And all of those different things are going to vary from company to company. And if it's not validated extensively, you could have a situation where you're getting either false positives or false negatives. And that relates to the fact that we have circulating common cold coronaviruses. And I think in the HKU, there's like 4 and they're all random names. So I'm not going to list them because who cares about trying to remember those. But one of them has 50 to 60% cross-reactivity with the spike protein of SARS-CoV-2, which is not a lot, but could be enough for something like IgM, or the first antibody that's produced after infection, that is very sticky, might accidentally bind to that, and then getting a positive test that maybe isn't really positive. And so all of these things that in terms of manufacturing of the test can lead to faultiness down the road, and then trying to determine based on, is it an IgM, as I mentioned, is this first more innate like antibody where it's more quickly produced, but it is kind of sticky. It's not very specific, provides some protection, but you really want to wait for that IgG with the nice high affinity to really show you that you have an antibody against it that's specific. So that's the reason why there's a lot of issues with this in terms of sensitivity and specificity. And you have to weigh those things. I think Daniel was talking about in the clinic, they had, you have to test that and weigh their different options, and then they can decide, okay, this is the one we're going to use. And if we're determining policy based on this, that makes me very nervous because of this reason. I mean, if you're going to give somebody a test that says you're negative, you can't go make money for your family. But in fact, it wasn't a sensitive enough test because of, for whatever reason, that makes me very nervous. So, and because the regulations are relaxed, which I understand in this circumstance, but that's what we're dealing with right now. It's very complicated.
That's only one of many reasons I find this whole thing makes me very worried.
Right.
I mean, the real issue is that, does this test actually tell you are protected?
No.
Well, that's a whole, right. So that's a whole another bag of worms with this idea of correlates of protection, and protection is even kind of used loosely. Does this antibody to whatever protein they're putting in there, which is probably proprietary, they don't tell you, does that mean you're protected? We don't know. And so if you're telling people you can go back to work, but maybe that's not a protective level and people are different. So it's,
I think it's
Vincent,
very,
that's key.
Very questionable. I don't think they have a choice. I think they have to do this, and they're going to see if it's positive on this rapid test. Are most people not going to get reinfected? Because as you know, you need to look at neutralizing antibodies to tell if you're protected. These tests don't distinguish.
Nope.
And boy, if you want to make some money, figure out a 15-minute neutralization assay.
Wow, that would be amazing. There's a challenge for the listeners.
Although I guess, and you immunologists, tell me, if you knew which epitopes generated neutralizing antibodies, couldn't you make a assay specific for those, or would that be too hard?
I don't think it's epitope to epitope specific.
Yeah.
Well, but we know on flu HA, for example, what epitopes give rise to neutralizing antibodies and others do not, right? So
if we use the receptor binding domain, only the part of the spike protein that binds to receptor, I suppose, if you had an antibody that bound that, it would tell you, but it doesn't mean that there are
subset. Yeah,
it doesn't mean that there aren't other antibodies that could also neutralize.
So
I think
that's the problem here.
Yeah.
If you have an epitope that is a neutralizing epitope, not every antibody against it, some of them will be slightly different and they won't neutralize it.
Exactly.
That's right.
Yep.
Got it.
And there might be other antibodies that bind to a different part that still might be neutralizing because of the way they induce a conformational change too, I think.
Just trying to make money for us, that's all.
Okay, we'll scheme after
It's
this
not
and see
so
what we come up with. So we have about 5 minutes left. So Cindy, am I assuming that 2 p.m. is a hard deadline?
I can hang out a little bit longer than that if you want.
Okay. Well, that is really kind of the summary and serology. I'm going to let you all pick out, unless we want to do a part 3. I'm always up for talking about this stuff.
We should do a part 3. I don't think you should rush anything.
Okay. Mike. That's fine. So we can either masks are big. Yeah. So if anyone feels passionate about any of these questions, or we can read a listener email, I'll leave it up to you, whatever you want.
Steph, you wanted to say something about WHO, which I think is a fine organization.
Yes, I actually
I
Cindy
put that in there. Yeah.
Yes.
Yeah. I don't know. What do we
Relevant.
say? What do we say? So I'm distressed, to say the least, that I'm seeing that the president is withholding funding for the World Health Organization.
Middle of a pandemic.
In the middle of a pandemic.
Not sure.
And I feel like I don't know what to say about it. It's irresponsible. It seems like a power play for not taking responsibility for what's going on here and trying to place the blame somewhere else where that doesn't make any sense. And so I'm fearful for what's going to happen to us. Not that the World Health Organization is going to deny us stuff. I mean, I think they understand that not everyone in the U.S. agrees with what our president is saying. But I think we need to we need to worry about generally how continued, over time and continuing even today, this administration is viewing science and public health officials. And I think it's a part of the reason why we are where we are right now.
Absolutely. I think that we mentioned earlier that this is sometimes making us think about immunology in terms of the population instead of as the individual. And I think that in a similar way, we have to realize that we need to be thinking about what's happening in protecting us against viral infections like this in the world. It's not as if viruses are doing different things country by country. No. And the World Health Organization is really important in us thinking globally about what's going on with these infectious diseases. And we can't just worry about what's going on here. We need to think about what's going on elsewhere, because that will impact whether or not we see infections here.
Yeah. I mean, I think any large organization is going to have its flaws. I think the Ebola outbreak in 2014, I think WHO did get criticized for some of its responses, but they had worked to, make sure the responses were quicker and better. I think, yes, there are points to criticize, but overall, in terms of a net benefit, this is an organization that is needed if we're talking about pandemic preparedness and allowing countries to be able to respond by sharing information and providing resources online that, maybe a lot of governments are not able clearly to, like ours, potentially to respond quickly, and even governments of smaller countries who have even less structure. So the WHO is something that really can serve as a source of structure to provide information and to have a consistency. And without it, despite its flaws, we're worse off. I mean, that's the thing about viruses and infectious disease. They travel borders. It doesn't matter. We're not in, 1820 where we're not traveling across the world in a second in an airplane. I mean, the reality is it's 2020 and we can cross continents in a day, and we need a World Health Organization. So the timing of it, I mean, it's crazy. So I think we could say in general, we're very pro WHO and also holding them accountable for when they slip up, just like we should hold ourselves and our government accountable for our responses.
Absolutely.
Yeah. Ending on a light note, you said travel across the continent in a day. Did you see this story about these people who took, it was an Audi, I think they got in there, and because there's nobody on the road, now this is theoretically, I think, but they said that this was anonymous, but they drove from New York City to California in like 28 hours.
Wow.
Isn't that insane?
Is that possible? Is that even possible?
I don't know. I did the calculation, and for like 3,000 miles, it was like 115 miles per hour for 28 hours straight. That doesn't seem possible to me.
That's crazy.
That seems a little crazy, because I know you could take Route 66 across, but it's not a straight shot, and so I can't imagine that you could stay that speed constantly.
And it's hard to imagine there was absolutely zero people on the road.
Not a single cop.
Yeah, because listen, I drive around. I see there's a lot going on in the Research Triangle here at Durham. Yeah. There's a lot of people on the road.
So who knows if that's true, but I thought that was pretty funny.
That's fun.
All right, that's Immune number 30. We'll have part 3.
Oh, part 3.
And probably 4 and 5 and 6.
So send in your questions.
We're going to have serology results that'll be interesting to see, and all sorts of things, vaccine results. So stay tuned. You can find this podcast on any podcast player. The show notes are at microbe.tv/immune, and send us your questions and comments at immune@microbe.tv. If you like what we do, consider supporting us, microbe.tv/contribute. Cindy Leifer's at Cornell University over on Twitter. Cindy Leifer. Thanks, Cindy.
Thank you.
Steph Langle's at Duke University. Stephanie Langle on Twitter. Thank you, Steph.
Yeah, thanks. This was great.
And Brianne Barker's at Drew University. BioProf Barker on Twitter. Thanks, Brianne.
Thanks. It was great to join you all.
I'm Vincent Racaniello. You can find me at virology.blog. Music on Immune is by Steve Neal. Thanks for listening to Immune, the podcast that's infectious. We'll be back very soon.